2025 ASMBS. Once again, here to talk to Dr. Rogers. She, of course, is the outgoing president. She's been the president for last year, and I've been excited about this conversation all day. We did a pre-interview, and you are obviously fired up about this subject. And as I've gone through the pre-interviews and I've gone through the whole day of doing interviews, I find myself just mind-boggled. Like, I can't understand how you guys function in this system that has a disease process. It's obviously a huge problem for America and the world. And yet it seems like all the other players involved in this, nothing's happening. Like, nobody seems to even notice it. There's the wheels aren't moving at all. Can you, from your perspective, you've been dealing with it now at the top, the head of the society for last year, you know, running the show. Can you kind of explain to us what it looks like from that perspective?
Oh, we've been saying the same thing for so long. And every president since the society existed has been talking about the fact that we operate on 1% of people who theoretically qualify, who have the disease of severe obesity. 1% in this world. It's unbelievable. And why can't we move the needle to operate on more people, to offer this service to people who have this terrible disease? I don't know. And this is what we're trying to do. We're trying to find a way to make people realize this is a true disease. You have a disease. It's a medical condition, and we have medical treatments. Let's get it out there. It's incomprehensible to us, truly.
It absolutely seems like at every level there's failings. It seems like from a preventive standpoint, whatever's going on in our food sources, whatever, they seem to be ignoring that. And then on the back end, all the different treatment modalities we now have, and nobody wants to cover it, or they lie about their coverage of it. and then I just found out from Dr. Peterson that we haven't even the government has updated the guidelines of Medicare for since 1991.
Well, part of what you said about the food industry, you know, a lot of people are profiting by the fact that we have this problem, right? The advertising industry, the food industries, you know, a lot of people are profiting by the fact that we have this problem. And, you know, obesity was only recognized as a disease maybe 10 or 12 years ago. You know, the American Medical Association finally decided to put a resolution out there saying, this is a disease. You know, we all knew it was a disease for a long time, but now, you know, doctors can say this is a disease process. But I think a lot of doctors, while they can say the words, may not have really internalized it to the point that they truly believe it, and kind of blame patients. And patients themselves may not really know that it's a disease. A lot of patients really blame themselves. So that's why the theme of my year has been ending the stigma of obesity. And guess what? We haven't succeeded in doing it, right? I mean, maybe the tip of the iceberg, but this is what I'm trying to do, is make people realize it's not your fault. This is not a character disorder. This is not a lack of willpower. There are so many biological and genetic reasons for obesity. It's a disease, and it's a disease that not only wants to be there, it wants to come back.
I mean, do we think humans have changed so much since the 1950s and 60s that all of a sudden human willpower just went away and now we have a problem? I mean, it seems like there has to be, when 70% of your population is overweight or obese, when you have 4 times the number of patients growing or in the area of BMI over 60 or some ridiculous number. I mean, these are
really taking off quickly.
Yeah, there's a huge problem here, right? And it's not it's relatively new in the world that now we have this issue. So I don't know how we can't look at this and say, wow, we should have everything, all of our research should be looking at this and what's going on? Why is this happening?
A lot of things are happening, one of which is portion sizes have gotten larger. Processed foods now exist. And it's only since the 1970s that people have even gotten to live to be in their 70s. So, you know, evolution is really happening very quickly. And that includes the obesity epidemic. So food has changed a lot since the 1950s and 1960s. So eating out is a different thing. People used to eat at home. They used to make their own food. And what we eat has changed a lot. and how we eat has changed a lot, and how we cook has changed a lot. Many of my patients have no idea how to cook a meal. They take all their meals at, Piggly Wiggly or Turkey Hill or whatnot. I've had patients in my clinic who I say, can you cook a meal? No. I'm like, can you fry an egg? And I had one lady tell me, well, I can crack an egg into a bowl and microwave it. And I'm like, okay, so that makes kind of a Frisbee in a bowl. It's like, it's incomprehensible, but people do not even know how to cook anymore.
But the thing is, and I agree with you, and a lot of people will listen to that and say, well, they need to learn. It's like, yeah, but they wouldn't, if we would have created the same environment.
They're raised that way.
But that's what I'm saying. If we would have created the same environment that you're in now, and we would have put the people from the 1950s in this environment, you end up with the same outcome. I don't think it changes the outcome because they're special people. I think that we've created a toxic, it's like putting fish in a toxic water and then going, well, I don't understand why they're sick.
Yeah.
And you go, what do you think's going to happen?
What do you think is going to happen?
And the more I hear the numbers, because I was under the impression, at least somehow this was slowing down because there's only so much obesity we can deal with.
Yeah.
And it turns out, no, the numbers are actually continuing to climb and they're spreading across the world.
Exactly. And we did some Hill visits today, and we were talking to staffers of many of our lawmakers about trying to get parity in insurance plans and whatnot. And some of the staffers said, well, my lawmaker wants to focus on prevention. And that's all well and good. But when 2/3 or more of Americans have overweight or obesity, that ship's already sailed. People already have the problem. You can try preventing it, but they already have it, and people have the genetics when they're in utero. They already have the problem before they're even born. So, you're talking about preventing something for the future. We need to deal with something right now for people right now. That's what we need to focus on.
Yeah. I mean, once again, 70% of our population, I listen to this all day and I just keep thinking, how can we ignore the fact that, and it's funny because people will be like, well, it's their own fault. It's like, you're also obese. Like the same person saying it may also be in that boat.
And how's it a fault thing?
Yeah. And that's the thing. Oh yeah. Like where do you see, you've been working on this all year. How do we change that stigma?
Listen, it's kind of like if somebody gets cancer and they have a cancer operation and then the cancer comes back, we feel bad for them. And we try to find other ways of treating it. We feel bad for them. We don't blame them. We don't blame the doctor. We don't blame the treatment. It's like, oh my gosh, we got to go to plan B or whatever. If somebody has an operation for obesity and it comes back, we immediately say, what did you do? You ate, blah, blah, blah. It's like immediately we blame the patient. Or maybe we say, oh, you did a bad operation. There's always blame, stigma. No. It's a very aggressive disease. It wants to come back. It tries very hard to come back. It's just like the most aggressive cancers. And we've got to think of it in the same way. It's got to be multimodal treatment, just like for cancer, because it's that kind of disease. And we got to put blame aside. It has nothing to do with fault, blame, willpower, or anything else. This is something that patients have, and they want to have help. They need to realize it's not something you're doing. Who wants to be heavy? Who wants it?
Oh, yeah.
Right?
I look at these patients that that they're trying so hard.
And they're so ashamed.
And it's not, and as we know, I mean, this is one of those, let's say you go on a very severe caloric deficit and you lose, your body's
starving.
And then they're starving and then their body's going to figure out a way. And it's like, and it's going to figure out a way to keep that weight on, even when they're doing things and they're trying so hard.
And by the way, can you quit eating cold turkey? No, you can't quit smoking. You can maybe quit smoking. Maybe you can quit drinking. And I'm not saying it's easy. You can't stop eating. So then people see them eating and then they feel the stigma from themselves, from their families, from where they work. They may go hide in their car to eat. It's terrible.
And inside of that, we have a food industry that has created different ways of making you want more. So they're industrial at an industrial level saying, here, I'm going to create something that forces you to want it.
Calories.
It's utilizing those biological processes that we have in our body and making us crave them. And that's something that we don't really talk about. It's like, it's one thing if you get people, apples are good. If you get people to eat them again, they're like, oh, I forgot how much I like an apple. But an apple doesn't have a chemical in it that makes me want to eat more apples.
That's right.
And
that's right.
And yet,
you're really hungry if you do want an apple, right? You're absolutely starving.
Yeah.
If you want an apple.
But it goes back to that processed food comment you made earlier. It's like now we're eating foods that didn't exist.
They did
30 or 40 years ago.
Yeah. And they figure out what those craving things are. And that's one of the things that works with those GLP-1 inhibitor medications. They hit those craving areas. And that's why they not only work against your desire for certain foods, they work against your desires for alcohol as well. So I have a friend who's going to be speaking at this meeting again about using GLP-1 receptor agonists against opioids. It's so interesting. These medications are really, really effective at that.
Really?
Yeah.
No, that is interesting.
Yeah.
Because I mean, it is happening. There's effects on our brain that obviously that all these things are having, and we blame the patients when they're not being told.
It's not their fault.
Yeah, they're not being told
they don't know.
They don't know that.
Yeah.
I always go back to it. I hate to pick on one thing, but like MSG basically, we put it on all this stuff and it makes us just want to eat more. So we have an obese population and we're putting stuff on food, processed food that makes them want to eat more.
Right. And they don't even know.
And they don't know that. And of course, who wants to tell them? Because then the people making the money on it, they're not going to talk
it's about the restaurant.
Exactly. So, but the fact that this conversation, obviously there's the other side we're going to talk about, which is coverage on the back end. And why is it that you can cover this, but you won't cover obesity, which we're all fighting.
Yep.
But on the front end, going back to where's the lobby that's saying, let's just end some of this. Let's just start with one thing. Let's just pick one of these and say, we're just not going to let that anymore. Or at least going to tell the patients, you don't have to not stop eating it, but at least be honest with them and say, this, if you are eating this, it has this chemical, and this chemical is actually making you not realize that your satiety has been settled, and you're just going to keep eating this food for no reason.
That's right. That's right.
But that doesn't get through.
Yeah. I saw that you were speaking to Dr. Eric Smith earlier, and I saw something he posted on Instagram the other day that had to do with, okay, you can give people GLP-1s, but if you're not also telling them about those foods that they're eating that turn on their cravings, you're doing them a disservice. And I don't know if he spoke about that.
He did. No,
did he? Yeah. That's so true.
And he is. And he was so correct there. And once again, I'm not saying that there's some panacea, like if we just remove this product or if we stop that thing. But the fact that it's such a pervasive issue now in our society, and we are not looking at all levels from food supply through treatment, how do we get those that have already fallen ill to this disease? How are we treating them optimally? And then how are we preventing future generations from running into this problem too? Because obviously whatever we've done, it's caused this.
Yep.
We need to start affecting, because it's just getting worse.
Yep.
I mean, you're talking people BMI of 60. I was told in one of the interviews, it's 200 pounds overweight. I mean, at BMI of 60, you're looking at 200 pounds overweight.
Those higher BMIs are taking off faster than the BMIs like in the 40s, which is your typical patient with severe obesity. So the very highest BMIs are taking off even faster.
Yeah.
And I think somebody's going to be speaking about that at this meeting. And it's terrifying, because those people are really sick and really at risk. And what's going to help them? These GLP-1 medications are not going to begin to get them anywhere near a normal BMI.
Yeah.
Yeah.
And as you said, these are humans. So these are our friends.
Yeah.
These are our relatives, our colleagues.
Yeah.
Like they don't want this either. They don't want this disease. And if they had heart disease, or if they had developed diabetes, or if they just had type 1 diabetes, or they're going to get treated. And even if heart disease, like, you didn't go out and run enough, or you didn't do enough exercise.
Yeah, correct.
I'm not questioning that cabbage.
Yeah. Yeah.
So
exactly.
So what is it? I mean, like I said, you've been at the leadership position level. Why can't we get the insurance companies or Medicare or somebody to really go all in on this and start working on it?
I don't think most of them really believe that it is a disease, first of all. They really are in the mindset that it's the patient's fault and they should just get their face out of the trough and it would take care of itself. So a lot of insurance companies come up with hurdles to keep patients from being able to get the surgery, because it's their fault anyway. So why should they have to pay for it? Okay. And some of these hurdles are things like prolonged time that they have to spend in programs before they will authorize it. And imagine, if you will, that you have a hernia. So you go to the surgeon and they say, yes, you have a hernia. Now we're going to schedule it and we'll fix it. What if they had these artificial things where they say, oh, now you have to go into a program for 6 months and prove that you won't strain, right? It's the same sort of thing. It's madness that anybody would do that. But that's what happens to patients with obesity. Prove that you'll be good and you'll eat less or you'll lose a pound or whatever. These are artificial things that make no sense whatsoever. If a patient has the disease of obesity, they should be able to meet with the surgeon. We have a surgical treatment and they ought to be able to get that treatment.
But the other thing is, you're also, from a psychological standpoint, you're almost forcing them to fail. And then it's a psychological, so you're making them go through this process where they feel like they're failing again.
Correct. And this is what happens. And then if they, and so when people do get bariatric surgery, metabolic bariatric surgery, generally the weight loss is sort of a bell-shaped curve. So the vast majority of people will lose a certain amount of weight. Some people will lose a lot of weight. Some people will not lose that much, and it's based on genetics. So if they are in the lower end of the curve where they don't lose that much, they feel like they've failed even at weight loss surgery, but that's not true. It's genetics. It's something inexplicable. And maybe those are people that also need medications or something else.
Which in and of itself, just that, what you just said, points to the fact that there's not as much control as people think. If you're doing something as drastic as a surgical rewiring of their system and they still can't lose weight, how hard do you think it would have been for them to do it by
on their
walking
own?
more and eating? Like, I don't even know.
Not possible.
Yeah, and it has to feel, it has to be overwhelming for that patient population.
I'm sure it is.
To just sit there and go, man, how is it I'm willing to put myself
I'll
through
do
this?
anything.
I'll do anything. And yet,
and
still,
even that didn't work.
Still, I can't get there.
Right.
I can't imagine as a human being.
Yep.
I always feel something. I went through a medical issue and then I had to face it again and I thought I was doing well. Yeah. And it's like, then I had to face it again. I was like, it was like, heartbreaking.
What have I done wrong?
Heartbreaking.
Yeah.
And yet to look in the mirror and know that the world's judging you and blaming you. Yep. And then you're saying, look, I'm trying. I'm really trying. And
I'm doing my best.
Yeah. That has to be
awful. It's awful. It's hard enough just being a patient.
Yeah.
Right? Yeah. But there's something really special about being a weight loss surgery patient, which is just like the demands are almost insurmountable.
And I've heard people make the comment, they'll say, no, not here, obviously, but in the past, well, that's the easy way out. It's like,
oh, please.
Yeah. Like, I don't think that that's the way we should be saying.
Of course not. My friend, Adrian Dan, who's the program co-chair here, maybe you'll meet him, has said, talking about the easy way out makes no sense, because if you're in a house that's on fire, are you going to take the hard way out or are you going to go right out the front door? Like, why should you take the hard way out? Of course you're going to take, and by the way, it's not the easy way out, but why do we put that on people that they should take the hard way out, right? Yeah. Take the only way out that there is. Get out of the burning building.
Especially, it seems like if you're one of the higher BMIs, especially, don't you want to show them a positive trajectory and get them feeling
somehow,
and then they're more likely to start doing more activities, more like, because then they'll feel better. If you start feeling, get some of that weight off, then your knees aren't hurting, your back's not hurting. Like, it seems like let's speed them up and get them feeling like there is a way to a solution. Hope. Instead of saying, no, we're going to make you feel like there's no hope.
You're going to jump through hoops. It's going to be really difficult.
So okay, you fought this battle. Your career has been fighting this battle.
Yes. Unfortunately.
What would you, if you had a magic solution to this and you said, look, here's the first outline, like what would be the steps that you think the system needs to take at each level? So, from a government standpoint, from an insurance standpoint, from a pharmaceutical, like what is the solution plan if we were going to have to outline?
Recognize that it's a disease, get universal coverage for this disease, and make it easier for patients to get access to this care. It's so simple. It's just so simple. That's what needs to happen.
And what would you say to the doctors, especially the ones that maybe are not as willing to see this?
Well, one of the things that we talked about at the obesity summit that we held in March, where we had, oh my gosh, we had doctors from every walk of the world, which was great, not just surgeons, but family doctors. We had PAs, we had nurse practitioners, we had endocrinologists, cardiologists, you name it. We all came together talking about the disease of obesity so that we would all work together to figure out how we solve this problem. And one of the things we talked about is just how to talk to patients about the fact that they even have this problem. And, you know, as bariatric surgeons, it's easy for us because that's why we're taking care of patients. You know, how long have you been heavy? How long have you been wearing the weight? Blah, blah, blah. It's really easy. Other doctors don't even want to go there. They don't even want to talk about it. They think it's insulting. And it's like, no, we've got to make it easier to even have the conversation because it's not insulting. You're not putting these people down. You know, they want to talk about it too, but they don't want to be yelled at, right?
And I think there have been horror stories that made it through social media where a doctor brings up the fact that somebody's over. Now, obviously, there's two sides of every story, so you don't know how they broach the subject, how they approach the patient. So I don't want to make that assumption. However,
they don't want to be blamed, and they don't want their medical problems to be poo-pooed or necessarily to have everything blamed on their weight, and they don't want to have things dismissed or disregarded and just blamed on their weight. Like if they have a real problem, they don't want somebody to say, "Oh, just lose some weight and that'll go away." Right?
Yeah.
Yeah.
So you say, I guess, how would you approach that patient, if you don't mind, kind of just to represent it? So you have a patient, you know, they come in and even though they have hypertension, they have diabetes, they're, let's say, 50 pounds overweight.
Yeah.
How do you approach them, and what is the best avenue to bring up the fact that there is an obesity issue without feeling like you're blaming them?
Well, I don't know the complete answer to that, but one thing I wanted to look at, in fact, I wanted to have it be an abstract at this meeting, but I couldn't get it off the ground for reasons that we can talk about. But I wanted to poll my family doctors at my institution and say just 3 simple questions. A patient comes to you for a physical exam and, oh, by the way, they have a massive inguinal hernia. What do? Send them to the surgeon. Patient comes to you for a physical examination and, oh, by the way, they have symptomatic gallstones. What do? Send them to the surgeon. Patient comes to you for a physical examination and, oh, by the way, they have a BMI of 50. What do? Oh, that's not why they came to me. See the difference?
Yeah.
They don't want to even address it.
Yeah.
They don't think of it as a surgical issue. That's the first thing. We need to recognize it as a problem, and it is a surgical disease. And we deal with it in the same way as other surgical diseases.
And I do think that there's probably some multifactorial issue there. I think that some doctors probably are afraid that they are going to embarrass the patient by bringing it up. I have seen doctors where they're like, it wasn't what they're there for.
Do you think the patient doesn't know?
Oh, no, and I agree with you. I'm not making the argument for the doctor. I'm just saying that I think that one of it's getting the doctor to realize that, look, you got to kind of walk into this knowing that this has to be broached, even if they don't, you're embarrassed. It's almost like they're embarrassed by it.
Yeah, I think so.
But then, of course, there's the other ones that, you're right, they just purely don't see this as a surgical problem, and they're going to just kind of ignore it because they're like, oh.
If somebody came in with a big tumor growing out of their head, would you just avert your gaze and not even discuss it? I mean, it makes no sense.
Maybe if you're an orthopedist.
Well, they don't even recognize it.
But that being said, yes. No, and I hear you.
Sorry, some of my best friends are orthopedists.
Oh, same here. I thought about it before I said it, but I still had to walk into it. Luckily, they're not the biggest on my platform. But all that being said, I hear you. And how do we get the popular? Because I've heard this for 15 years now. I mean, 20 years maybe, that we know this is surgical disease. The bariatric surgeons, I mean, you guys have been screaming this from the rooftops that we have at least a partial solution or starting to have a solution to it. I mean, and now with the advent of the GLP-1s and we have a multimodality therapy that really seems to have benefit, how do we get them to see that?
Part of the problem is they only have 6 minutes to see a patient, right? So maybe just normalizing the whole concept of it being a disease, more brochures in the waiting room. This is a disease. mailings to people with a certain BMI. This is a disease. It's not your fault. It's not your fault. Just getting the message out. And one of the things we're probably going to work on is direct to consumer marketing. So they realize it's not your fault. It's a disease. It's not your fault. It's not your fault. Just getting that message out.
No, I know talking to Dr. Peterson, he brought the fact that like ASMBS.
Yeah.
You guys have a multiple specialty groups. So it's not just surgeons here. There's all the medical professionals, everybody else. How important is it for the surgeons to understand the medical management and really make sure that when the patient goes in there, they don't feel like they're seeing a surgeon and that they're going in and, but allowing to have the population, in that office that gives them all the different opportunities. Because I think that everybody's been right. Like knowing about GLP-1s is a big deal because the patients here, it's medication. Maybe I can do this. And then it introduces them to all the options that they have,
right, and
really allows them to then explore some of these things because I know for me, I've sent patients, I'll be like, I'd love to see a bariatric surgeon, and they go, I don't know about surgery, and
right.
So is it something that we're really trying to do that to retrain that mindset and say, look, let's just get them in the door and let's start the conversation.
Yeah.
And because I know that they hear bariatric surgery, dietitian, I failed at diets, I don't want surgery. But the reality is they don't know anything about surgery, so they don't know what they...
Good point. I mean, Rich wants it to be one of his initiatives that people get more education about obesity because it's something that a lot of people don't learn about at all in medical school or PA school or nursing school. So that's a major failing, and that's something that needs to be corrected. Many bariatric programs do also have an obesity medicine component, but not all. But I will say that most of my patients now are coming to me already on those medications. So a huge number of Americans are on those medications and know about them.
Oh, and I think that is the one thing that's really come out of this is they're talking about it now.
Yeah, they know about it. And
once they start to see some benefit, I think that they may be more open to say, look, I got this far. It's
normalizing the fact that, oh, this is a disease and there is a medical treatment. Now, maybe it won't work for them. And then they'll realize, well, if that didn't work, then maybe I should consider surgery. Yeah. And that's why we don't fear them.
Yeah.
Yeah.
But either case, like I'm excited to finally see something moving the needle.
Yeah.
It seems maybe.
I have hope.
I'm sure you've had hope for a while.
Yeah.
So after decades in this field, what would you say is the pearl of wisdom that you've taken from the whole thing?
After decades in this field, what pearl of wisdom? It has been very hard not to give up hope, but we all love what we do. And this is our home. This is our family. It's super interesting what we do, and we love our patients. Our patients are they're very reverent. They love us and they know that we get it. And so that's what makes it possible for us to keep going in and keep doing what we do. It's a special population. These patients are different from most surgical patients. We see them long term, they follow up with us and they appreciate what we do. And that's huge.
Well, as I said to Dr. Pearson, the one thing that I really noticed is the level of compassion across this entire surgical community and the requirement of having that compassion.
That's great.
It really seems to permeate your society, your members, from the leadership down.
That's great to hear.
And so I do appreciate the work that you are trying to do. And after I get the opportunity to go to these different societies and sit down with, experts for 2, 3, 4 days and really talk to them. And it's very eye-opening.
That's good.
In a positive way. And it's really changed my perspective on a lot of aspects of the field.
That's fantastic.
I truly appreciate it.
Then we've done a good job.
You have. Now I just want to try to get that message out to everybody else. So thank you so much.
Absolutely.
And thanks for being on the cutting edge.
It's been a pleasure.